some questions, and our time is over. So if you Mark agree, we could give 15 minutes, 5 minutes per panelist, and once more for Dr. and Dr. Phones, because they have questions. I will have one question for you too, Edson. I will send to you. And Dr. M, please, if you could start to respond to the questions.
Okay, so I take the questions from the chat, right?
Yes.
Yes, okay.
Yes, yes.
So I would say the choice of the cities for the Novartis Foundation, we chose those 4 cities, first of all, because we wanted to have at least one city in every big region, that it would be representative and replicable in that region. Then we looked at the burden of disease. We looked at cities that have a very high cardiovascular health burden, but also the needs in the health system, and mainly the local engagement. When we didn't get a first feeling that the health authorities in the city in question were happy to engage in such a partnership and open to innovate the way they were thinking about health and care, we wouldn't engage, because we know that that is really a condition sine qua non. On the other hand, we also wanted to know that there was a potential for success, so it had to be a relatively stable context. When we look at Mongolia, for example, we chose Mongolia because it has the highest cardiovascular mortality on Earth, but second only to Afghanistan. And of course, there the choice wasn't difficult. We couldn't start working in a conflict area, and that's where we went to Mongolia. For Brazil, we ended up choosing São Paulo because it is really a megapolis that is representative for many other Latin American cities. The burden is very big, and the local engagement was fantastic as from the start. So lastly, another criteria for us was that there was really an openness to innovate, but also a potential for sustainability, for impact at scale, and for multi-stakeholder engagement. So I hope that answers the first question. You want me to quickly go to the second one as well? So the second one,
yes.
What is the protocol, the hypertension protocol we used in this project? Does it follow the PAHO or the WHO HEARTS protocol? In fact, our teams on the ground were supporting the development of the protocol and the rollout of it. So when it was defined, we made sure it was rolled out to the health professionals in the city. But the protocol itself was established by the Secretary of Health, the Municipal Secretary of Health, together with the input from the Brazilian Hypertension Society, the Society of Cardiology for the state of São Paulo, and local nephrologists, primary care practitioners, and several other stakeholders. So we took the input definitely from the WHO packages, and the HEART package was at the basis of it indeed. We also took the existing hypertension guidelines available in Brazil, and then all the other guidances from the medical societies. But the protocol itself was owned and published by the city of São Paulo. So that's for sure. And then the last question was, what were the activities for encouraging healthy lifestyles or risk factors? And what were the indicators and outcomes of all the interventions that we had measured? So the activities in the healthy lifestyle area were very variable, but they were including advocacy for physical activity, or we did healthy nutrition education, both through the primary healthcare center, but also through the community ambassador programs, through the educational materials that was distributed via the community health workers who are much more closer in touch with the patients. And lastly, also in the schools, obviously. The new protocol really incentivized the outreach to primary care services to the communities through screening and awareness campaigns. And we've seen that that has been very successful when the primary care centers really go outside of their buildings and do these awareness and screening campaigns. We had a lot of people showing up, and that established also afterwards, we also established new patient groups who became bigger advocates even than any other of the health workers or the local ambassador champions could be. So that was very useful. And then the indicators we were using for Better Hearts were really focused on the cascade of care. So starting with the number of people screened, that meaning measured their blood pressure, and we installed screening opportunities in every health center for any person who would present in the health center, not only those who came with a suspicion for a cardiovascular problem or high blood pressure, but everybody coming to the health centers, also the moms coming with their kids, everybody would get to measure their blood pressure. That's been very successful because there were lots of missed opportunities otherwise. And so that's one example. Also in the pharmacies, in the community awareness days, and as I said, with the football and samba champions, we also did that. But we measured the number screened, and then based on that, the number diagnosed and the proportion of those who really got confirmed diagnosis. From those diagnosed, how many got treated, and from those treated, how many reached blood pressure control, and after how long. So that were the different outcomes we measure, because we know that if you control blood pressure, you increase the risk development, decrease the risk development for cardiovascular events. So blood pressure control equals decreasing risk for cardiovascular complications. And then lastly, we also looked at the health system performance in the city of São Paulo, and specifically in terms of the procedures conducted, and in terms of how patients with hypertension were handled. So I hope that answers.
Yes, thank you, Dr. Ann. Dr. Phones, please, if you could respond to the questions for you.
Thank you, Fatima. Yes. I find two, by the way, so I'll go to these two. The first one says, you stated that, especially for NCD, we have knowledge of how to intervene. Why do you think healthcare systems struggle with the implementation of those best practices? Well, that's the million-dollar question. That's the riddle we haven't been able to solve. But what we do know is that it has very many angles. The high-level commission, just to land on something very concrete, we have tried to address and evaluate and assess this from different angles, from different platforms. The latest of this was the high-level commission that I mentioned in my intervention, and that has, in its report, you will find some narrative and some assessment of what are the main challenges identified for implementation, and some of the solutions. The solutions are basically the recommendations coming out of the high-level commission, but the challenges certainly are, go from all the way from lack of political will at the highest level, and that has to do with governance mechanisms for NCDs and cross-sectorality. The ministers of health alone cannot and should not be addressing this problem, and governments, even though they can be cross-sectoral, alone again cannot be addressing this. It needs partnerships, it needs collaboration, it needs cooperation, and it needs action across the different elements to help systems, help governments address and a comprehensive solutions. It's also, as you saw, we've heard about lack of financing, and we heard of the impact of commercial and social determinants. We didn't touch on that a lot, but economic, social, and environmental determinants that impact on health call for this cross-sectorality. But if we unpackage that, we can see that some of these are also impacting on prioritization of health systems, on efficiency and effectiveness of health systems, and on the needed financing that does not reach health systems but does go and is diverted elsewhere. We could go on, but I think the challenges are there of implementation, and I think the solution is partnerships, collaborations, and coming together to solve this, coming together to support our health systems, understanding the integrated approach that we saw today about on how to address primary healthcare, people-centered primary healthcare, understanding how we can and where we can integrate and where we can't, and sometimes there's a lot of elements there. But I think just working together is just the start, and probably the start and the platform that will take us to the solutions. Then the second question, if I can find, this is a good question. Is COVID expected to make on-track countries out of track to achieve the SDG 3.4? This is what we're all across the health system sort of alarmed and extremely concerned at. Probably the COVID will take countries off track many goals and targets, certainly not only health, but beyond. It is devastating to the health and economic systems across the world. But what I was trying to also highlight, that within that awful black cloud, which is the COVID pandemic, there is an opportunity to understand that NCDs, the solution to NCDs is to integrate it fully and timely and efficiently and for good into the UHC discussion. And then as our panelist, as Edson was saying, the implementation platform for the UHC is primary healthcare. So integrate that into primary healthcare in a comprehensive, integrated, life-force approach will help then those countries that are not on track and that are suffering also from COVID to quickly combine both and try to continue the progress towards the SDG 3.4. That's it from me.
Thank you, Dr. Fons. Thank you very much for your contribution. Dr. Edson, please. Dr. Edson, you are mute.
Hello, thanks, Fatima. You see, technology is not my strength today. Thanks for the question, Otávio, and good to hear from you. I think that's a good point in terms of what we expect from in the next years, given there's so much spending on health and on response, immediate response to COVID. And that's not only in Brazil, it's globally, right? To see from low-income accounts, mid-income accounts, high-income accounts, everybody running to set up a basic response with surprisingly very few count ahead. But I think this also brings some medium and long-term good perspective, because as we know now, not everyone was prepared for this type of situation, which means we're going to need more investment on the basic surveillance, preparedness, and all these things you're talking here about primary health care, UHC. It's clear that we need to have a stronger health system to deal with this situation. And even though the increase in costs in Brazil, but globally, for respond to the COVID, they are significant. We are on the health sector alone. We are spending quite a lot. If you think only the World Bank has put $16 billion to help countries to respond to it. But we know only Brazil spend much more at all levels of government. But if you look also at the economic impact of it, we have a new report for in Brazil estimating the impact of the COVID, and it's about 5% of GDP. So which means the economic costs are much higher than what we actually spend now on response. So I think from the long term, even medium term, for the next years, I expect that health and SUS and public health going to be in the agenda, because it's clear for everyone that the not doing what we should do results in much higher costs, and the investments are significantly lower than what we are facing here in terms of economic, of course, in terms of life lost, but also in terms of employment loss, economic activity stopped. So I think in the next years, the prospect is good, but we need to do it wisely, right? Cannot just increase the spend without looking at what's really needed and what's the most efficient way to do that. Thank you. Over.